Thanks very much for that introduction, Rhonda, and thanks to the organisers for the invitation to speak today. It's a real privilege to be a part of APHIA here in Bangkok. So as I've mentioned, my topic today is the implementation of the virtual cross-matching technique in Australia and the perspective of our laboratory, and a little bit in regards to the laboratories nationwide, as this was a nationwide change. And I'll be talking about the deceased donor virtual cross-match implementation. So in Australia, BV, before virtual, our deceased organ donation process was supported by the complement-dependent cytotoxicity test, which was performed prospectively in the donor state laboratory. In order to facilitate this, we prepared cross-match trays monthly with serum from all of our active patients of all of our transplant programs. These were manufactured monthly and exchanged around the country each month. So, big workload involved in that. And that method supported the deceased donor allocation program for decades in Australia and supported it well. But meanwhile, in the background, there were numerous technological advances that we were implementing to improve our histocompatibility assessment for all of our organ transplantation programs, including the obvious introduction of HLA antibody screening using the Luminex technology, which we introduced routinely into our laboratory in 2007. We introduced it in a very limited and targeted way, mainly due to the cost. We were also able to introduce nationally the use of the real-time PCR HLA typing technique in 2013, and so we were able to improve our histocompatibility assessments to include all loci and high-definition antibody detection using our Luminex antibody detection beads. So these results were available parallel to our cytotoxicity techniques cross-match results at the time of organ allocation. I apologise, that didn't show up as well as I'd hoped. Another strand that was coming into this discussion at the time was the targets for deceased organ donation and in Australia. The Organ and Tissue Authority had set a goal of 25 donors per million population around the country. Apologies, this hasn't shown up quite so well, but here in Victoria, where our lab is based, this is from 2023, we had 142 organ donors, successful organ donors last year at a donation rate of 20.8 donors per million population. So there's a little way to go yet to hit the target of 25. And in order to improve these donation rates, our organ donation agency are exploring more complex donors, older donors, donation after circulatory death, which obviously has an impact in terms of donor work that does not proceed to transplantation. And with a hands-on time of around 8 hours to facilitate the complement-dependent cytotoxicity cross-match, this is a real consideration of the sustainability of our workforce going forward. So the complement-dependent cytotoxicity method, it underpinned our organ allocation program for a very long time for some very good reasons. The ability to share sera nationally on the cross-match tray system to provide a prospective cross-match was a big advantage. There was a high level of familiarity amongst the clinicians that were accepting these results. It does detect clinically relevant antibodies, and it's an economical test. It's easy to train staff to perform the test, including reading the cross-match results and interpreting. But it has some drawbacks to it, including that it is time and labour intensive, and also declining use internationally means that we were struggling to support it with quality reagents and good equipment. But possibly the biggest issue at that time was the apparent limited sensitivity of that test. And this is just from the BISHI and VTIS guidelines on detection of alloantibodies, where a negative T and B cell cytotoxicity crossmatch in the presence of Luminex DSA, the CDC is unable to stratify risk beyond the Luminex or a flow crossmatch. But also importantly, a positive CDC crossmatch in the presence of no DSA are all considered standard risks. So the cytotoxicity crossmatch was adding very little to the interpretation of the histocompatibility of these donor and recipient pairs. And in addition to this, the increasing publication of the significance of donor-specific antibodies and graft outcome meant that we were seeing a lot of organ declines due to the presence of donor-specific antibodies in the presence of a negative CDC crossmatch. One final strand that really was able to move us forward in virtual cross-matching was we were lucky to be able to implement a new organ matching system, which was custom built for the Australian community, which was implemented in 2019, the Organ Match program. And one of the important changes we were able to make in Organ Match was consistency of the way we report our HLA typing and our HLA antibodies to move to the molecular format. So our typing and antibodies were in exactly the same format. And the Organ Match was built on a platform that allows us to hopefully grow and expand that program as our needs change as well. So we had ourselves a number of strands coming together that said to us, we need to change, but what are we going to change to? We couldn't recreate the system that we were using with cytotoxicity, just swap out CDC and put in flow. That was not going to work in a country the size of Australia. So we needed a new approach. And obviously numerous publications about the use, implementation of virtual cross-matching and its success internationally really gave us, and our own experience with increased Luminex screening really did give us a push that virtual cross-matching was the way to go for us as a national allocation scheme. And that was easily said, but a lot of work went into laying the groundwork for the change for this is a big change. So just at this point, I would like to acknowledge the Virtual Crossmatch Working Group that participated and really drove this change forward, particularly Narelle, Watson, Rhonda Holdsworth, and Ross Francis for their work in bringing this about. For us in the laboratory, there was a huge amount of change required, particularly we introduced EDTA pre-treatment for all of our Luminex single antigen bead testing for the removal of interfering agents such as this complement molecule. We were able to do this across the country, which managed to standardise our pre-treatment and remove variability. Some we were performing hypertonic dialysis, some labs were using heat treatment or DTT. So we were able to standardise that across the country. Another major change for our lab was the increased frequency of HLA antibody screening. Prior to this change, we were performing a Luminex single antigen screen once every 12 months, which was woefully inadequate to support a virtual cross-matching program. So we increased our frequency from once a year to 4 times a year, which I have to say gave our lab such an amazing learning experience in terms of how the antibody profiles react, how they remain stable or not, and also gave us a really great confidence in being able to recognise patterns, see those denatured bead reactions that we do see in all of our patients, many of our patients, and gave us increased confidence to be able to recognise those, call them out, and correctly assign HLA antibodies. We introduced the Halifasta Rapid Flow Crossmatch Protocol, which provided a valuable second tool for, as I say, interrogating those Luminex antibody results. And it gave us an opportunity to be much more responsive to changes in antibody profiles. We could reach out to the units and ask, what's going on here? What's happened to this patient? And I feel that really established groundwork of what we need to know from the transplant units, how they can proactively give us this information without us having to reach out after the event. So there were a number of national education webinars, newsletters for the virtual cross-match change. But to be honest, we found we needed education at our local level directly with our transplant units to be able to give them confidence in this change. And it sounded quite simple, but even just the statement that a patient such as this, where There's no HLA class 1 antibodies, there's no HLA class 2 antibodies by Luminex. This patient has a negative cross-match. This patient has a negative cross-match not just with this donor, but the next donor as well. Even that concept was enough to make our heart unit just go, okay, that I understand. But 50% of our heart list is sensitised. It's not always this simple. So that was Virtual Crossmatch 101. We moved on to Virtual Crossmatch 201. This is a patient who is sensitised to class 1 and their donor HLA typing profile as obtained by the real-time PCR test, so low resolution. And I've highlighted the mismatches of this particular donor against the recipient, and we can see that all the beads are negative. And again, predicting a negative cross-match. Again, seemed to us to be a simple concept, but again, valuable for our transplant units. But when there is a DSA present, what do we do? And the concept was already well established in renal groups. In 2016, we'd implemented calculated PRA using a threshold of Luminex MFI based on Luminex detectable antibodies. And so introducing this concept to the other transplant programs in the country, particularly our heart and lung programs, was really critical to the introduction of virtual cross-matching and allocation algorithms. So we were fortunate to have a staff member commence a PhD with the Melbourne lung unit around this time, looking at investigating the role of HLA mismatching and DSA on CLAD and lung transplant survival. So Steve published this paper in 2022 in HLA. He spoke yesterday on the influence of HLA alleles in the Australian donor population. So we were able to use this paper to inform our unacceptable antigen calculation thresholds. This was a national change, so national negotiations were required to establish an MFI threshold for unacceptable antigens as an introductory point. So we didn't actually land on the thresholds suggested in the paper, but we have introduced the concept, and I will come back to how we plan to expand that later. So for our lab, the Victorian Transplantation and Immunogenetics Service, we support a broad range of groups. We have adult and paediatric kidney, heart, lung. We support multivisceral liver and pancreas islet transplantation. And there were different expectations of the system and different thresholds that we landed on for all these different transplant programs. The threshold concept for unacceptable antigens is a very easy to understand one, but it doesn't get into the nuance required for a patient's unacceptable antigen profile, unfortunately. And that really required direct communication with our clinical colleagues, which we were able to build as a result of this virtual cross-match implementation. Particularly the conversation that a threshold is not just the be-all and end-all. We needed to define the risk for the individual patient. Sorry, I beg your pardon. So we had direct conversations where, for example, if we set our risk threshold too high for a patient, we unnecessarily deprive them of potentially acceptable organ transplant offers and delay their opportunity for transplant. If we set our thresholds too low, we obviously waste people's time with unrealistic transplant offers that are not suitable for their needs, but also potentially increases the risk of acute rejection in the post-transplant phase. We were also able to have the conversation too that not all patients require the same risk profile. A stable lung patient with pulmonary fibrosis, the risk of undergoing a DSA positive transplant and desensitization protocols is not in the best interests of the patient, but an acute lung failure patient with the same sensitization profile may require more risk to be taken to achieve the transplant. And that was a conversation, that's not something we can obviously judge, but that direct communication with our clinical units was invaluable to be able to set these unacceptable antigen profiles run appropriately, not just for the organ program, but for the individual patient. So in order to cease CDC, we started with a stepwise cessation of the cross-match test. We started with our kidney and pancreas recipients and ceased CDC cross-matching for unsensitised patients. And then 6 months after that, we ceased the CDC cross-match for our sensitised patients. And for stage 2, we did the same in our cardiothoracic transplant population. And in the midst of that, we were able to introduce heart and lung allocation algorithms to make use of our unacceptable antigen profiles to define what's suitable and what is not from a histocompatibility perspective. And this stepwise process was done in sync across the nation because of the collaborative and cooperative nature of the tissue typing labs around the country. We worked together to make sure this was done in sync, and the same service was rolled out across the country at the same time. So in the after virtual world in Australia, we have a range of situations in which a retrospective flow cross-match, a post-acceptance immediate flow cross-match, or in very limited situations, the prospective flow cross-match. And the prospective flow cross-match is limited to patients where sensitisation status is unknown because of the urgency of the patient, but a potential for a sensitising event since their last screening result. They're really the only two that we do it for, and this is something we do for only our cardiothoracic and intestinal transplant patients, of which we have a very small number of intestinal patients. So, what makes us nervous? These are some of the things that do make us nervous, but it's worth noting that these all made us nervous before virtual cross-matching, not just after. Mary Divney will be touching a little later on changes in immunosuppression whilst patients are active on the transplant waiting list, what's happening in between those 3 time points. Establishing that good communication with our transplant units really gave us good basis for, they know we need to know about sensitising events, and most of the time they're good at telling us, so that allows us to really put in place ways that we can safely virtually cross-match these patients in the setting of these sensitisation events. And donor HLA typing complexities are another concern for us, particularly, as Steve alluded to yesterday, the donor alleles that are not on the panel, particularly DPB1, or rare or new alleles that we detect in our deceased donor population. And those complexities complicating our DSA analysis. And of course, having quadrupled the Luminex screening that we do in our laboratory, there's the obvious consideration of budgets. So some of the big challenges that we came up against for our virtual cross-matching introduction was that despite the decreased sensitivity of the CDC cross-match, it was considered a useful evaluation tool for some of our transplant units to transplant a sensitised recipient. And we were lucky to have the perspective of our clinical lead, Rob Carroll, to talk through these complicated cases and how in the clinical management of these patients in the face of a sensitised transplant. As I mentioned earlier, we're working constantly with our clinical colleagues to further refine unacceptable antigen profiles for complex patients, and there's more work to do in regard to donor-specific antibodies and unacceptable antigens at specific loci, and the possibility of applying different risk thresholds for our DPB1 or C antibody profiles. We may not be making trays, but we're doing our work in a different place. We're doing our work pre-transplant, where with our pre-workup, our workup space, we're able to dig in using those Luminex antibody profiles and define what these patients need in a much more thorough way, I think. And that regular clinical engagement has made us really think about what we need to do and how we can get these profiles set up best for our patients. And no perfect test does exist, but we do need and we use all the tools we have in our toolbox, and we're looking for more at all times. So just in summary, I would say that virtual cross-matching in Australia has been well accepted by our transplant clinicians nationally. We were able to introduce it successfully. We've been able to streamline the organ offer compatibility process for histocompatibility labs due to the use of the virtual cross-match technique. Virtual cross-matching allows the laboratories to support an adaptable allocation system to accommodate more extended criteria donors. And it's also been shown to safely support the national program of organ allocation and transplantation. And so with that, I say thank you to all the laboratories that worked together to implement this virtual cross-matching change. It was a huge amount of work, and it was a pleasure to work and introduce it. Thank you very much.
Is there any question from the floor? Please go to the stage. Okay, please.
That was great, Fiona. Very interesting. Thank you. I've got a couple of quick questions, and apologies if I missed either of these. So when you accept a patient for a virtual cross-match, do you have to send a report or something like that to the clinicians immediately, obviously before transplant?
Yes. Yes. So we're performing a virtual cross-match donor-specific antibody assessment on the recipient as part of the donor workup process. Yes, we perform a donor-specific antibody assessment, and that information is transmitted to the clinicians.
Okay, and sorry, my second question was, do you have to do a cross-match sometime after transplant just to prove, if you like, yes, it was negative, thank goodness?
Yeah, we did do a large study when we implemented the Halofaster the Halofaster flow cross-match method, looking at exactly those, using the predictive nature of the Luminex antibodies and to correlate with our Halofaster technique. We do retrospective cross-matching mainly on request across donor-specific antibody positive patients rather than the Luminex negative patients. They're the population we focus on. We will do it on request, is the main driver for that, but occasionally there's no requirement to do that.
Okay, great, thank you.
Thanks.
Yeah. Is there any question? Okay, so if no question, now I would like to invite and thank you, Fiona, for the wonderful presentation.